Ready. So just before we have discussed about acyanotic congenital heart disease like VSD, PDA, ASD, and acyanotic heart disease with obstructive like aortic stenosis and coarctation of aorta. The most important is that most common congenital heart disease in ventricular septal defect and most common complicated VSD by infective endocarditis. Just like coarctation of aorta, this is very important because there is chest X-ray 3 sign. In examination, it may be asked that what 3 signs found in which disease of the heart. Next, we have discussed cyanotic congenital heart disease like transposition of great vessels, where we have got this egg on side in chest X-ray and tetralogy of Fallot. Just we have seen this tetralogy of Fallot. So in tetralogy of Fallot, 4 things: pulmonary infundibular, RVH, overriding of aorta, and VSD. So here the X-ray finding is important. It is known as Coeur and Sabut or boot-shaped heart. Why boot-shaped heart? Due to right ventricular hypertrophy. Normal size heart, pulmonary oligouremia. There is no plethora, pulmonary oligouremia. Right aortic arch 25% patient. There may be right axis deviation ECG and inverted TOF or P-pulmonal. So these are the findings of Fallot's tetralogy. So squatting they relieve by squatting causes compression of femoral artery. So increase pressure, thereby decrease the right to left shunt and directing more blood from the right ventricle to the lungs. Next is Eisenmenger syndrome. Now, what is Eisenmenger syndrome? So it is uncorrected VSD, ASD, PDA. Increased pulmonary vascular resistance due to arterial thickening to progressive pulmonary hypertension. Uncorrected VSD, ASD or PDA with progressive pulmonary hypertension. As pulmonary resistance increase, the shunt reverses from left to right to left shunt, which causes late cyanosis, leading to clubbing or polycythemia. It is the most dangerous cardiac lesion in pregnancy. So Eisenmenger syndrome is the thus reversal of the shunt causes late cyanosis. Now, cyanotic congenital heart disease with obstruction, like pulmonary valve stenosis, and second is this is important. Now, let us come with common mixing congenital heart disease, that is acyanotic and cyanotic. So, one is a truncus arteriosus. Neonatal, there may be breathlessness or congestive cardiac failure. This is very not important, but what is important is the total anomalous pulmonary venous connection, TAPV or TAPVR, total anomalous of pulmonary venous connection or return. Newborn, the obstructed venous return just simulated RDS, 2 months to 2 years, supracardiac type of most commonly. So there is cyanosis not improved in 100% oxygen. 100% oxygen, the cyanosis is not improved. There may be poor pulse, and in chest X-ray, there is pulmonary edema with snowman heart. This is known as figure of 8 heart. This is also important. In examination, they will ask that figure of 8 heart in which condition. So total anomalous pulmonary venous connection. So it is a figure of 8 or snowman heart. So these are the important regarding all this congenital heart disease. So there may be some procedure to relieve cyanosis or restlessness in anoxic special tetralogy of Fallot. Number 1, knee chest position, that is squatting position. We can give humidified oxygen, morphine, propranolol, and acidosis, correct acidosis with IV sodium, and vasopressor may be used, IM or IV, and correct anemia, and finally there is operation. So this is Fallot tetralogy. Now what are the operation treatment of this Fallot tetralogy? So there are 3 operations. One is Blalock-Taussig shunt. Blalock-Taussig shunt subclavian artery to pulmonary artery. The shunt is from subclavian artery to pulmonary artery. Second is port shunt, descending aorta to pulmonary artery, and water shunt, ascending aorta to pulmonary artery. So three conditions. One is blaloctosis, very old. So subclavian artery, in this case, subclavian artery to pulmonary artery, subclavian and pulmonary artery. So this is important. Now, there are some simple additional points regarding this congenital heart disease. In adult, ASD is the most common congenital heart disease. VSD is second. PDA is beneficial. PDA, ductus independent flow, beneficial if flows to embodied in certain conditions. So what are the conditions in which PDA patency is beneficial? Number one, hypoplastic left heart, pulmonary stenosis, Eisenmenger's physiology, and TGA with intact ventricular septum. These are all conditions in which PDA, persistence of the PDA is very important. Now, what is Shone complex? SHONE. Shone complex is coarctation of aorta plus mitral valve abnormalities. This is known as Shone complex. So, one is Rose procedure. What is Rose? ROSS procedure. Rose procedure is replace a patient's damaged aortic valve with his or her own pulmonary valve, that is autograft. This is important. So one is autograft. Rose procedure is replace patient damaged aortic valve with his or her own pulmonary valve. So autograft. Next, the pulmonary valve is in turn replaced by a human donor valve, that is homograft. So in Rose procedure, there is two, autograft also and homograft also. This is very important. So what is Rose procedure? Now coming to the very important day-to-day most common disease is rheumatic heart disease. So rheumatic heart disease is a sequence of pharyngeal infection, group A beta hemolytic streptococcus. Here is type 2 hypersensitivity, not direct against the bacteria, type 2 immune mediated. There is certain criteria known as Jones criteria, major criteria and minor criteria. So Jones criteria, one is the carditis. There may be Merger, carditis, mitral valve most common involved, and MR is most common disease. So one is pancarditis, number one, MR most common disease. There is a Caricum's murmur. Now what is Caricum's murmur? It may be heard due to MR soft, low pitched, mid diastolic murmur. So in carditis, there is Caricum's murmur. It is a diastolic murmur, low pitched, mid diastolic murmur. So carditis is the most common major criteria in rheumatic fever in children. So you remember that in children, carditis is the most common, whereas in adult with rheumatic fever, it is arthritis. So carditis most common criteria in children, rheumatic fever, and arthritis is most common in adult. Second is migratory polyarthritis. No residual joint damage. Now damage response to salicylate. A dramatic response to salicylate. So polyarthritis, one is carditis, polyarthritis, it is a migratory, one joint involved, next joint, first joint already cured. So there is migration of this joint. Third is chorea, that is known as St. Vitus dance. Estrogen or pregnancy can cause recurrence. So chorea, St. Vitus dance. Fourth is erythema marginatum. Focus this erythema marginatum, very important because in this case face is spared. Face में नहीं होता है erythema marginatum. And subcutaneous nodule. It is non-tender along the extensor surface. It is often associated with carditis. So these are the major criteria. So one is pancarditis or carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodule. Now, what are the minor criteria? In minor criteria, clinically हम लोग देखते हैं there may be fever, arthalgia, previous rheumatic fever or rheumatic heart disease, and in lab investigation there is RAGE, ESR, CRP, leukocytosis, and ECG, that is prolonged PR interval on ECG. Okay, so these are the Jones criteria. Now, there is American Heart Association revised the Jones criteria in 2015. The salient features between older criteria is inclusion of echocardiography for diagnosis of subclinical carditis. So they include echocardiography. In case of rheumatic mitral valve prolapse, it may be noted that only the left leaflet tip will bend into the left atrium. So this is very important. In case of rheumatic mitral valve prolapse, it may be noted that only the leaflet tip will bend into the left atrium, unlike the body of the valve leaflet in classical mitral valve prolapse. So in case of non-rheumatic mitral valve prolapse, there is the body of the valve leaflet, they bend into the left atrium. But in case of rheumatic mitral valve prolapse, only the leaflet tip will bend into the left atrium. So in examination, it may be asked that in Jones criteria, rheumatic mitral valve prolapse, only the leaflet or the body of the valve enters into the left atrium. So this is important. Another important highlight is inclusion of monoarthritis and polyarthalgia. Monoarthritis and polyarthalgia at potential major criteria in population. Okay, so this is the revised Jones criteria. Jones criteria में होता क्या कि only two major, if diagnostic initial two major manifestation or one major plus two minor. Now in recurrent rheumatic fever, two major or one major, two minor or three minor. Okay, so we have seen that there are 5 major criteria and certain minor criteria. So major criteria: carditis, polyarthritis, chorea, erythema marginis, subcutaneous nodule. Minor criteria: low risk population में polyarthalgia, fever more than 38.5, ESR more than 60, CRP more than 3, and prolonged PR interval. In moderate high risk population, there is monoarthalgia, ESR also raised, CRP, all these things are common. So these are the acute rheumatic fever. Now prevention. Prevention, I think it's not important because everybody knows that what are the drug of choice in this. So when antibiotic therapy is provided within 9 days of pharyngitis, acute rheuma can be prevented. Now, what is the drug of choice? It is a single intramuscular injection of benzathine penicillin. If benzathine penicillin is allergic, then erythromycin is drug of choice. So in penicillin allergic condition, erythromycin. Now, suppression therapy. So acute suppression therapy. For 12 weeks, aspirin used if no carditis and corticosteroid used if carditis present with CCF. Okay? So you can give aspirin and corticosteroid. Now, what are the secondary prevention? Secondary prevention is that single intramuscular injection of benzyl penicillin, 1.2 million unit once every 3rd week. So single intramuscular injection of benzathine penicillin every 3rd week. Patient without proven carditis should receive prophylaxis for 5 years after last episode or until age of 18 years, whichever is longer. Now, patient with carditis, that is MR or healed carditis, should receive prophylaxis for 10 years after last episode or until 25 years of age, whichever is longer. So this is the criteria of giving benzathine penicillin in rheumatic fever. So these are all about the congenital heart disease, cyanotic, acyanotic, rheumatic fever, Jones criteria. So we have discussed all these things.
Okay. So like we can summarize like congenital heart disease acyanotic cardiovascular heart disease. So VSD, ASD, and PDA, and cyanotic heart disease. There are uh, TOF, Tetralogy of Fallot, TGA, TAPVC. There are cardiac anomalies like VSD and ASD. So
Yeah.
so there are cyanotic and acyanotic heart disease. So overall, even if there is a clinical picture, in a clinical picture, if we want to differentiate between cyanotic heart disease and acyanotic heart disease children, how can we like differentiate? Like in a clinical question, if you want to set a question, like
No.
different, how to like make a question, like your perspective.
Right. Right. Suppose a patient is suffering from acyanotic heart disease, so there may be breathlessness, there may be tiredness, there may be palpitation. All these things happen in acyanotic. There is no cyanosis. So suppose there is a VSD or PDA. So patient may complain of this. There is something machinery things. Sound comes from my chest. In case of adult, but in young baby, so they are not giving any sign symptoms. But if we see or the mother felt that patient is not taking this milk, there is some difficulty in taking sucking milk. So there is some breathlessness. So we can see the inspect or palpate and this auscultate the condition, and we see the different types of murmur present in the child. Number is wide spread, variation as to subdermal pansystolic murmur, left this external border, or there may be continuous machinery murmur. So different type of murmur in different condition we can see. So we can diagnose by auscultation and by giving this chest X-ray. So in case of children, there's young children like 2 years, 1 year. So these are more common. Now in adult also BSD, ASD, and PDA is common. So the patient complain of there is some breathlessness or exertional dyspnea, and there is some chest pain or uh, they are easily tired. So these are the conditions in which we can proceed for diagnosis by giving certain type of X-ray and hematological test. So we can found that there is some defect. And echocardiogram is also important. We can see that there is BSD, ASD, or some other condition. So this is a cyanotic, but in cyanotic heart disease, the patient is already suffering from cyanosis. एग्जॉशन होगा तो उसको कहेगा कि भाई हमारा ओठ जो है उसको ब्लू हो जा रहा, नेल सब ब्लू हो जा रहा, पेशेंट को दिक्कत हो रहा सांस लेने में. सो दिस condition we may investigate for this different types of cyanotic heart disease.
Yeah.
So overall this that cyanosis, cyanotic heart disease patient present with cyanosis or cyanotic spell present due to compress, or whenever there is some reversal of the shunt in case of Eisenmenger, there is cyanosis. So cyanosis is clear cut. There is cyanosis, central cyanosis. Okay. So we can differentiate by giving X-ray and all investigations, and then we proceed for further management of the patient. Okay.
Okay. फ्रॉम ए क्लिनिकल एक्सपीरियंस अभी तक, मतलब आपने जो देखा है पेशेंट्स, तो उसमें कुछ आप लाइट देना चाह रहे हैं बच्चे लोग के लिए?
नहीं, इसमें है ना कि जो कॉमन होता है जैसे टेट्रोस्टेक्टोलॉजी, वन पेशेंट आई हैव सीन दैट पेशेंट उसका स्टंटेड ग्रोथ, वो लड़की का स्टंटेड ग्रोथ था, इजीली उसको ब्रेथलेसनेस होता था, और उसको बाद वो ओठ और नेल और जितना भी फेस जो है वो साइनोज हो जाता था. उसको जब ज्यादा ब्रेथलेसनेस होता था तो वो बैठ जाती थी स्क्वेटिंग पोजीशन में. स्क्वेटिंग पोजीशन में बैठने से देखते तो उसको आराम होता था. तो दीज आर ऑल क्लासिकल पेशेंट आएगा तो उसको देखना है कि ये सब कर रहा है क्या, तो उसको हम लोग देखेंगे कि स्क्वेटिंग पोजीशन उसको भी रिलीफ मिलता है, और उसको जो है एयर हंगर हो जाता है कि भाई हमको सांस लेंगे परीक्षा, तो उसको हम लोग देखते हैं. जे साइनोसिस इज वेरी इंपॉर्टेंट. तो उसके बाद हम लोग ऑस्कल्टेट करते हैं या एक्सरे लेते हैं, तो डिफरेंट टाइप्स तो नॉर्मल पिच आ जाता है. तो ये कंजेनिटल हार्ट डिजीज इज मोस्ट कॉमन, लेकिन इसको हम लोग ट्रीटमेंट जो है तो चाहे तो इसका पैलिएटिव ट्रीटमेंट है या तो हम लोग प्लेटिव ट्रीटमेंट देते थे, नहीं तो फिर सर्जिकल ट्रीटमेंट करके पेशेंट का फेलोप्स में कम सर्वाइवल होता है, और 13 14 15 ईयर्स में पेशेंट कोलैप्स कर जा सकता है।
जी
तो
ठीक है।
क्लिनिकली तो हम लोग यही देखे हैं कि साइनोटिक हार्ट डिजीज में एक केस पेशेंट हमने देखा था फेलोस टेट्रोलॉजी, तो उसमें उसका क्लासिकल स्क्वाटिंग पोजीशन करती थी, और उसके बाद उसको जो है डेथ वाज ड्यू टू कंजेस्टिव कार्डियक फेलियर। तो
ठीक है,
ठीक है, इसी तरह होता है। ओके,
प्लीज कंटिन्यू ब्रो।
तो नेक्स्ट हम लोग विल डिस्कस सम रेस्पिरेटरी सिस्टम।
यस। In there also there is one typical Kawasaki disease. It's not there in the heart, but in the Kawasaki disease यहाँ पे एक क्वेश्चन बनता है कि वो बेसिकली ना उसमें फीवर, रैश, लिम्फेडिनोपैथी होती है, और उसका
हम्म
ट्रीटमेंट है एस्पिरिन और इंट्रावेनस इम्यूनोग्लोबुलिन। सो एस्पिरिन इज
हम्म
वेरी इंपॉर्टेंट ड्रग जो कावासाकी डिजीज में दिया जाता है। पीजीआई चंडीगढ़ में सर ने वहां रख के काम किया था इस पे, और एस्पिरिन
हम्म
को यूज किया गया था, एक कॉमन दवाई डिस्प्रिन, उसको यूज किया गया था
हम्म
कावासाकी जैसा डिजीज में। तो जैसे
हम्म
आप अभी डिस्कस भी कर रहे थे, जैसे एंडोमेथासिन, या फिर हम लोग मतलब पेटेंट डक्ट को खोलना, डक्ट को बंद करना।
हम्म
तो बच्चों को
हम्म
ऑब्वियसली थोड़ा सा एम्ब्रियोलॉजी पढ़ना होगा, तब जाके इसको और ज्यादा
भैया,
क्लियर होगा, राइट।
इम्यूनोलॉजी भी साथ साथ में पढ़ना पड़ेगा।
हाँ
तो उसमें भी कुछ कुछ कंडीशन इम्यूनोलॉजी से रिलेटेड है, तो हम लोग उसको बारे में डिस्कस करेंगे।
ठीक है।
हम लोग कवासाकी के बारे में भी डिस्कस करेंगे।
हाँ,
ठीक है।
तो रेस्पिरेटरी स्टार्ट कर सकते।
टुडे रेस्पिरेटरी।
ओके, नेक्स्ट नेक्स्ट सेशन हम लोग कर सकते हैं रेस्पिरेटरी।
नेक्स्ट सेशन, नेक्स्ट सेशन वीक।
तो उसमें लगभग हम लोग क्या क्या टॉपिक देखेंगे, जैसे रेस्पिरेटरी डिस्ट्रेस सिंड्रोम बच्चों में बहुत कॉमन होता है, कॉन्जेनिटल डायफ्रेगमेटिक हर्निया।
पहले तो हम लोग देखेंगे कि रेस्पिरेटरी इन्फेक्शन,
राइट।
डिफरेंट रेस्पिरेटरी साउंड्स,
राइट।
respiratory infection, different type bronchiolitis, pneumonia, pulmonary alveolar proteinosis,
हाँ।
cystic fibrosis,
हम्म,
uh, and this COPD, chronic obstructive pulmonary disease.
ठीक है।
These are things.
ठीक है। न्यूनेट्स
This
में
is
तो
these things.
कॉन्जेनिटल डायफ्रेगमेटिक हर्निया ये सब क्वेश्चन आता है, वो मतलब।
हाँ, तो नेक्स्ट हम लोग उसके साथ डिस्कस करेंगे पीडियाट्रिक गैस्ट्रोएंटेरोसाइटिस।
हाँ।
जीआईटी में करेंगे कंजेनिटल डायफ्रेगमेटिक हर्निया, जो लास्ट ईयर क्वेश्चन आया था,
हाँ।
जिसमें लास्ट ईयर क्वेश्चन आया था कि बुगडालेक हर्निया,
अच्छा।
बुगडालेक हर्निया
ओके।
कहाँ मिलता है,
हम्म,
ये क्वेश्चन था।
ठीक है।
तो दो कंजेनिटल हर्निया होता है दिस पीडियाट्रिक्स में, एक मॉर्गाग्नी हर्निया, एक बोगडेलिक हर्निया।
हम्म।
मॉर्गाग्नी मीडियम में होता है, मीडियल साइड जिस डायफ्राम,
हम्म,
और लेटरली होता है बोगडेलिक। तो उसको हम लोग डिस्कस करेंगे।
ठीक है।
सेकंड, यूटेराइन ट्रैकियो एसोफेजियल फिस्टुला के बारे में डिस्कस
हाँ
करेंगे।
कैफ। ठीक है।
हाँ, इन्फेंटाइल हाइपरट्रोफिक पाइलोरिक स्टेनोसिस को डिस्कस करेंगे,
हम्म।
और हिस्टप्रूग डिजीज को डिस्कस करेंगे।
फर्स्ट टू बिजनेस, ठीक है।
हिस्टप्रूग डिजीज इज वेरी इंपॉर्टेंट, लास्ट ईयर क्वेश्चन आया था।
हम्म।
क्वेश्चन आया था कि इन हिस्टप्रूग डिजीज, in which nerve plexus absent in which layer of colon।
ओ।
ये बहुत इंपॉर्टेंट, दो दो प्लेक्सस होता है इसमें,
हम्म।
आइडबैक प्लेक्सस एंड मिजिनस प्लेक्सस।
हाँ।
इसके बारे में हम लोग डिस्कस करेंगे।
ठीक है।
न्यूट्रोनेक्राइजिंग इंटरकोलाइटिस भी डिस्कस करेंगे, और बल्बुलस इंटरसेप्शन। ठीक है।
ठीक है।
ओके।
ओके। एक
ओके,
अच्छा
विल
सेशन था।
फाइंड अप।
हाँ, विल फाइंड आउट। ओके तब।
ओके।